Dr. Feinman is a fertility doctor at HRC, which is actually one of the biggest clinics. There's 9 locations in Southern California, and he's a board-certified reproductive endocrinologist, as well as in obstetrics and gynecology, and he's been in the field since 1986. Not to date you at all.
Yeah, it's all right. There's some benefit to experience.
Exactly. He's been doing incredible work, groundbreaking work on assisted reproductive technology, and performed one of the first transvaginal ultrasound-guided egg retrievals, and he also developed an anonymous egg donor program at the Albert Einstein College of Medicine in New York. So thank you for joining us and talking about the various kind of ways of assisted reproduction, and particularly IVF, and how does that work when we are dealing with a male factor.
Well, thank you for inviting me. Well, first of all, as you're talking about through these many fascinating and fantastic sessions, our urology colleagues have made incredible strides in helping men who were previously thought to be, shall we say, sterile, I hate that term, to actually have children. Once sperm is miraculously obtained from these men, the female partner needs to go through in vitro fertilization. This sperm is not adequate for simple insemination procedures. Of course, most men don't fall into this unusual category. However, many couples with male factor issues will ultimately need IVF with intracytoplasmic sperm injection, or ICSI. Now, some couples with mild to moderate male factor can undergo intrauterine insemination, or IUI, before going on to IVF. In some cases, the male factor can be improved with procedures like varicocele repairs. I'm sure that's been being discussed, and when appropriate, hormonal therapy. Once all of that is investigated and possibly done, IUI can give reasonable chances of success if it's possible to concentrate around 10 million motile or swimming sperm for the insemination procedures. Some people actually consider 5 million to be adequate. Other factors, such as the female age, should be considered when proceeding with IUI below 10 million sperm to make sure that precious time is not being lost. Most of us feel that attempting IUI with less than 5 million motile sperm in the final processed specimen is probably not worth it. Now, there are a family of tests known as DNA fragmentation assays that might help couples decide if IUI is appropriate. These tests evaluate the stability or quality of the DNA in sperm. Some papers have actually shown that when the DNA quality is poor, as done by these types of tests, the pregnancy rates with IUI are not better than nature. Once there is a decision possibly to go on to IVF, I'd like to discuss briefly the process, including the screening, along with, of course, some of the possible complications. Briefly, obviously, at this point, the male part has been taken care of. So the female partner needs a few things to be looked at first. One very important aspect is what we call ovarian reserve, or her ability to respond to the so-called fertility drugs and make multiple eggs. This is done usually through a combination of ultrasound and blood tests done on any of the first 3 days of her period to assess the amount of follicles that her ovaries contain, and the blood tests are indirect measures as well. An important and sometimes ignored test is the hysterosalpingogram, or HSG, also known as the X-ray dye test. This is the only test that can both evaluate the uterus and the fallopian tubes at the same time. It's obviously important to make sure the uterus is shaped normally. And in addition, people need to know that when there's a type of blockage at the end of the tubes known as a hydrosalpinx, the presence of those tubes will lower the IVF success rates by 50%. So it's important to do this old-fashioned test before going on to IVF. Some women have had this all evaluated previously with a laparoscopy, which is fine but more invasive and surgical. In addition, most states, including California, require that the partners be tested for a variety of infectious diseases, including HIV, hepatitis, and syphilis. We're very proactive at HRC to encourage couples to undergo appropriate genetic screening. Genetic screening used to be rather costly, and we would only do a few genes, but now there are a number of commercially available and readily available genetic panels at very affordable prices that take the guesswork out or the worry about the cost of genetic screening. These tests will screen for things like cystic fibrosis, Tay-Sachs, sickle cell anemia, and Fragile X in the female. The reason this is so important is that while it's unusual for a couple to walk in together with both of them carrying a recessive trait like this, since if they are going through IVF, we will have the golden opportunity to prevent the transmission of these diseases to a child through the process of pre-implantation genetic diagnosis. So I think it's incumbent upon our colleagues to look out for these genetic diseases. The process of IVF starts with the injections of one of the various brands of fertility drugs to induce the production of multiple eggs. That process will require monitoring visits for ultrasound and blood. In our program, it's on average 3 times over a 10-day period. And when the follicles are considered ready, the eggs are considered ready, a final injection called HCG is given to trigger the process and get the eggs ready for collection. The egg retrieval is done, as you mentioned a few minutes ago, transvaginally using an ultrasound probe to guide a needle into the ovaries with light anesthesia, usually given to the female. However, the sperm are going to be produced either through the traditional method or through the more modern methods for men without sperms by taking the sperm directly from the scrotum. Later that day, through the process of ICSI, individual sperm are injected into the eggs. The next day, we can find out how many of those eggs fertilize normally, and 3 or 5 days after the egg retrieval, a small number of embryos are transferred gently through the cervix into the female's uterus in a process called embryo transfer. Most programs will supplement the women with progesterone after this, and then actually within 2 weeks, they find out if they're pregnant. The IVF process is considered safe, but like any medical procedure, there are potential for complications. These complications come from the 2 obvious sources, the drugs and the procedure. The use of the fertility drugs on rare occasion can cause the production of a huge number of eggs, over 20 usually, and on occasion after that, the women can experience a complication called hyperstimulation syndrome, where their ovaries get quite enlarged and can even weep literally gallons of water into their abdomen. The good news is that this is preventable. At HRC, we use an alternative to the HCG injection, which is actually the hormone that causes this complication. We use something called a Lupron trigger, which causes the women to have their own LH surge, and LH, natural LH, is far less likely to cause hyperstimulation than HCG injections. Putting a needle into the ovaries, of course, can cause some bleeding afterwards and infection. Fortunately, infection has proved to be very rare, and we give antibiotics to make this complication even less likely. The bleeding, once in a blue moon, a woman will report a few hours after an egg retrieval that she's in pain, and we discovered that there is a small bleeder in the ovary, and the majority of these patients can be managed with a night in the hospital, an IV, and bed rest. I mentioned PGD before, pre-implantation genetic diagnosis, in the area of testing embryos for genetic disease when the parents are carriers. PGD or PGS, pre-implantation genetic screening, can also be used to look at the chromosomes in embryos. This is becoming more and more of a popular alternative for couples. While not perfect, because no test is that perfect to completely wipe out the chance of having a Down syndrome or similarly affected child, PGD is useful to help couples consider single embryo transfer and reduce the complication of multiple pregnancies. Now, in the area of male infertility, particularly with ICSI, there has been some concern about the safety of this procedure. There are papers alluding to higher rates of certain complications or congenital anomalies in the children. And, of course, we're always vigilant and worry about this, particularly in the more severe male infertility patients, because these men in previous generations would not have had children, and now we are helping them have children. It would be comforting to people to know that in Belgium, where ICSI was first described and performed, a very interesting study was done a few years ago. They have a huge number of patients coming there from all over Europe, and they found a group of patients who happened to have their first child naturally and now couldn't have a second child. And these people then went through IVF with ICSI. They then compared the rate of congenital anomalies in the natural pregnancy group to the ICSI pregnancy group, and then compared those to the congenital anomaly rate in Belgium as a whole. And lo and behold, the congenital anomaly rate in the first two groups, the couples with male infertility who conceived naturally or with ICSI, were similar and slightly higher than the natural population. So there is the belief that the actual infertility may contribute to some of these concerns. Unfortunately, while they are statistically elevated, they're not clinically out of range. In other words, they were slightly higher than the general population, statistically significant, but still the vast majority of children born through these processes are healthy. So I hope I didn't talk too much, but that's a brief summary of the comparison of IUI and IVF. People might like to know that we are currently running an FDA trial that allows women 35 to 42 with certain qualifications to undergo IVF at a greatly discounted rate, and we can discuss how to contact me for that at the end of the session.
Okay, so I have a couple questions. I was taking notes while you were speaking.
Good.
So the process that you just talked about is very similar as it was a bit ago when I was experiencing it, but I feel, and maybe you can confirm this is accurate, that there's just multiple choices within the process. That the part about pre-plantation genetic testing and ICSI and all the new innovations, the process is basically the same of
Correct.
when a patient
It hasn't changed much in 25 years. Right.
Right, but it's the analogy that we maybe can use is the car analogy, but it's the bells and whistles that are on the car now, the options
exactly.
in the system. And
Correct.
so it's surprising to me that the histosapenogram is still the way of obtaining that information about the uterus shape and size and
yep.
positioning, and also the tubal functioning with the expansive options now that process. Now, is that done within your clinic, or is that an outpatient? That was one of the questions I had.
It's an outpatient procedure, can be done by radiologists. We happen to be one of the few programs in California, probably the country. There are a few others, but we actually have the machinery to do the test in our Encino facility, so that's an unusual arrangement to be able to have a reproductive endocrinologist perform the test rather than a radiologist. So the radiologists do a fine job. I'm not picking on them, but we do have it.
No, but it's a different comfort level for a woman, because that for me personally, I can only speak to my personal experience with having that done 3 times. It's uncomfortable, and then knowing that you have your reproductive endocrinologist, who mine did come and do the procedure for me because he was that kind of a gentleman, which seems like your clinic is also doing that it brings comfort. And I think the hardest, if we redirect it back to the men listening and the men component, because we are focusing on their part of this.
Right.
I feel that within my practice, it's important for both parties to be aware of the process, to both parties to be aware of what's happening when, but also
Absolutely.
for for the male component to know that this is an extensive process for the team. You know, if you look at the parent, the couple as a team.
Yeah,
but
of course.
But their process is just as important. There's not waving the flag. This is more important than that. Is more important.
Right.
Even Steve. And so thank you for that. And then the other question or note that I jotted down was about the procedure for retrieving the sperm from a man who might have a problem below the millions of sperm that is necessary. Now, who does that procedure? That was the other question I kind of jotted down. So.
In general, when there's any sperm in the semen, we try to work with that. So even if it's below 1 million, we can work with the semen. But for whatever reason, if we're going to get so-called scrotal sperm, either because the man has no sperm or through previous experiences, we suspect that the sperm from the ejaculate is poor. I mentioned that DNA fragmentation test. Some people believe that if we can't improve that test, that the scrotal sperm might be better than the seminal sperm in these unusual cases. So whatever the reason, if we're going to get scrotal sperm or testicular sperm, we work with urologists. So people like the excellent contributors to this conference are our friends and colleagues here in L.A. Some of them, Dr. Worthman, I know, is a speaker. They come over to our facility in Encino and do the procedure. They either do the procedure the morning of the egg retrieval, or on occasion we'll even do it in the afternoon prior to the egg retrieval, and we then can keep those sperm cooking happily in the lab overnight. In fact, the benefit of the split procedures is that both parties need a ride home. So on the day of the sperm retrieval, the wife or the female partner takes the man home, and the next day vice versa. But if they both have it done the same day, they know they need someone to drive them home.
Well, that was important to me, because when you were talking, I was like, well, that wasn't a personal experience of mine, but how does that work? Is there another? But how wonderful that is that it's in the same location.
Right. We do it all there in the same location.
Right.
Yeah.
Right. Okay.
Most of the, shall we say, up to the date IVF facilities can accommodate the urologist coming there. Obviously, some of that might be logistical, in terms of whether the urologist can actually get there. But for us in LA, it's not a problem. We're centrally located, and the urologists are happy to come over. And as I said, we give them pretty much 2 days to get over, the day of the retrieval for the woman or the afternoon prior. And we're always working in concert with them. So these, as you know, these are highly manipulated cycles. They're not like nature. So we can pretty much plan. We pretty much plan the week, and even within a few days accuracy, the day of the procedures, to be consistent with the urologist's schedule. Make sure he's in town, that he's not overloaded with other procedures or office hours that week, and so forth. So with the proper coordination and communication, it works out pretty well.
Well, there's part of my communication to my clients about when they're asked that question, Doctor. I'm sure that you've heard this, that the question of when you're going to have kids, or why aren't you two engaging in a family, or when you're going to give us the grandchildren. And the elevator speech that was my favorite when I was going through it was, we have a whole team of experts working on it. And what you just talked to is the whole team of experts working on your behalf to create the family that you are desiring. And I think I know that I watched a video of you talking about that, about how women and men and couples, regardless of if it's a heterosexual couple or a lesbian or gay gentleman, that there is a team of experts that are available to work on your behalf, and that you're not alone in this journey. And that also includes, the legal advice, the legal education that we've just received from Amy Dema, and then, Davina talking about banking on your future. If you have a diagnosis, a terrible diagnosis of cancer. So I think what you just addressed is that we are not alone. You're not alone in this. And I appreciate
the more professionals helping, probably the better off for the couple. We encourage all the things you said. We work with counselors that are even welcome to come to our office to meet with couples. We try to encourage couples to provide legal clarification of the disposition of their eggs, sperm, embryos in the future. God forbid there's calamity or divorce. So the more people looking over these folks' shoulders, the more comforting we hope they feel that they're being supported. You're totally right, and communication between our team and the urology team is also an important facet to help these couples feel comfortable that they're getting appropriate care.
Okay. So you brought up that you just triggered another question on my behalf. So when you have couples come to you and are freezing their embryos for another cycle, but we all know that the likelihood of the cycle working is up there. I always say that I have that belief that you're moving forward, and it's going to be as you manifest or intend. So within your clinic, do you refer people for the legal stance? For Amy Dema used such a great terminology for a co-parenting agreement, the intent to co-parenting or parenting agreement about freezing your embryos.
We don't require it. We encourage it, and either the couples can go to their own personal lawyer, or if they want a referral, then we would direct them towards excellent people like Amy to help them draw up that agreement. We totally agree with it. I've actually, believe it or not, been a speaker at American Bar Association conferences, and in fact, in a week I'm going to be at the Beverly Hills Bar Association, talking in panels with attorneys on this very important topic. It's like anything else, like genetic screening. It's 1 in 1,000 chance that a couple's going to walk in and both carry a disease and need it. But if you don't look for it, you don't find it. And the same thing with this. It's a rare occasion that a set of embryos or sperm and eggs might be, in the lab, and there's a conflict over what to do with them. Those are rare occasions. But, when they come, you sure would have liked to have that agreement. So protecting against rare occasions is still appropriate.
Right. So, and I just have one other question. So, if I'm a guy listening on the line, or going to listen later, driving home, and is really a newbie, really thinking that they've just been told that IUI or IVF is going to be needed for their creation of their family, what should a man expect going into your clinic? What happens to a gentleman when he comes in and has to make a deposit for these procedures? Can you just explain that so
sure.
that they have
well, first of all,
that?
Yeah. Go ahead. Obviously, the situation requires that the men bring a specimen at a certain time, somewhat on demand. Fortunately, for couples living within an hour or so range of the office, they can make the specimen at home. We encourage that. I always kid around with them. It's more fun at home. Obviously, less pressure, little better chance for intimacy during the production and so forth. And we actually let the sperm sit out. We let the semen, people don't appreciate this, but we let the semen sit out on the benchtop for at least 30 minutes in the lab before we even work with it when they produce it at the office. So there's no advantage to having it there immediately. Over an hour, sometimes there'll be some decrease in motility, but in truth, if it gets there within 2 hours, we probably can work with it most of the time. If they are living out of the area, we do have a rather brisk practice of international couples coming in from around the world to do procedures with us. So those those people will be encouraged to produce the specimen in the hotel. But if for any reason they're coming from further away, and our catchment area goes pretty far up the coast, so there are couples that live 2 or 3 hours away, we provide them a private and hopefully tasteful room to produce the specimen when needed.
Okay.
In some situations where there is anxiety or doubts or even concern about whether there'll be sperm in the semen, which is occasionally a problem, we will encourage the men to give us a specimen ahead of time, and we can freeze that specimen to have it as a so-called backup.
Okay, that's news to me because way back when
well, I'm glad I'm bringing news to you.
Yeah, that's awesome. Thank you so much. Thank you. So I think that maybe that will help lower the anxiety level of, what you see or hear, on the internet or read on the internet about how this is. But it's really comforting to know that you can do this at home and
well, yeah, we encourage it at home, or as I said, even hotel rooms. And if we've had a chance to talk about it ahead of time, there are those times that, as I said, we can freeze the specimen in advance. We can't laugh at these poor fellows. I mean, the women go through so much with the injections and the egg retrieval and all that, but the men do express some concern at having to sort of step up to bat, on demand, and so they sometimes find that just doing it randomly is easier. And so for those gentlemen, we happily freeze the sperm. In the old days, we used to freeze it on everybody, but it got a little cumbersome. So, we offer so-called frozen sperm backup, on specific cases. For the men with really low sperm counts, unfortunately, they don't freeze too well. So, at the bottom end of that spectrum, that's a problem. So those fellows sort of have to be able to do it. But for a lot of the men that have sperm in their ejaculate, they can freeze a specimen if this is an issue. Obviously, for the men going through testicular sperm extraction, this is not an issue.
All right. So I'll tell you, during our time, I was that patient that would have the sperm tracked all the time. I was in the fertility clinic waiting for my procedure, and they were so kind and loving to me. I'd be like, "Don't let it out of your sight." Like something would happen to it. But that was just part of the control issue, and I think I echo that with a lot of my clients, both male and female, that you are in a state of feeling so uncertain, out of control, that whatever can talk to that voice in your mind and put you at ease, and the way that you presented it and shared that information, especially for the male's point of view, that makes the whole situation shifted. So thank you.
Glad to help. You brought up something interesting. This is a little bit of a digression, but you might find it interesting, and our listeners might be fascinated to know that some of what you just expressed was at the heart of the concerns of the Orthodox Jewish community way back in the early 1980s when IVF came to the forefront. And there are actually organizations now, and I work with one of them called the PUAH Institute, PUAH. People might be incredulous or surprised to know that these organizations actually provide female supervisors to the lab to watch every step of the process, including when the sperm is delivered, to exactly what you said, to make sure that someone's got their eye on that specimen. And these, we call them the PUAH ladies, actually in the lab, watching every step from the time of the sperm production to the egg retrieval to the fertilization. Each critical step, they're there to verify and give comfort and security to these folks that the right sperm, right eggs, and so forth are being used. Not that there's a high rate of errors, but that was the concern of the Orthodox community way back in the day, and so amazingly they came up with this novel system of addressing it. Just to say that you're not alone. This was a whole cultural issue for some people in the early days.
Wow, who knew that? See, no, for me it was just fear. You know, it was just, and it was, unsubstantiated. You know, of course it was unsubstantiated.
But you're not alone in that fear. That's what I'm saying. And in fact, there's a whole community, you know, that shared that fear with you so much that until they could get through it, they wouldn't give their constituents permission to do IVF. Now they do because of wonderful groups like the Pooh Institute. But you're not alone. You know, you don't have to be orthodox to worry about it. But they came up with a way to address it.
Wow, that's amazing. Well,
now,
thank
fortunately,
you.
the rate of known. Go ahead.
Go ahead. I'm sorry.
No, go ahead.
Oh, yeah, I was probably that patient that had the star on. Oh boy, here she comes. But you know, from that whole, you know, my personal experience, it's what you said. You know, that it's a similar journey medically, like how you just rattled. How you thoughtfully explained the process. And we're able to, you know, you live that. You can rattle that off, I'm sure, you know, maybe in your sleep about how that process works and how systematized it is. There's also a very chartable way of looking at the emotional component to the journey also, and where you can troubleshoot the spike in emotional heightened around the procedure. And I think just being able to share the cycle and how it methodically is thoughtfully and systematically and medically overwatched, you know, it's such a peaceful way of doing it. Because I remember even way back when, even when you hear that once, and I know I don't know for sure, but I'm sure that you say that information over and over again to a client or a patient going through this, because the information, you know, at sometimes in a heightened state of an emotional state, it's hard to digest and comprehend that. So that's why I appreciate us taking this time and going over this and knowing that you have options even for, you know, the men have options of where, when, and how they produce their contribution, their important contribution to the cycle. So thank you.
You're welcome. I mean, we as professionals, we can, as you said, take it, you know, in stride what we're doing. But it's good to always try to remember what the couples are going through. And while the act of producing a sperm specimen might seem to the uninitiated as a simple thing to do, you know, there are issues for some people, and we have to be cognizant of them, give them as many options, and let them know that we're understanding and aware of it as possible. Right.
So, Doctor, what we have been doing through the conversation is really, you know, being so grateful for everyone coming on and sharing their wisdom and experience, and also asking, you know, what would be the one big pearl, if you could boil everything down to a pearl of wisdom for a man who is finding himself in this journey from a medical point of view, what would be the pearl that you would have a man take away or start to think about when they find that they're in the situation, maybe having a male factor fertility issue?
Well, I guess there'd be two pearls. One is you're not alone. You know, there are millions of men in your boat. There are 40% of the couples that come to us have a male factor involved. And perhaps equally important is to say, you know, just as a woman's femininity and identity is not tied to her eggs, there's probably even more of an issue for men, because all we really do is produce that specimen to make a baby. You know, we don't gestate it and carry it and all that. So, you know, there's some cultural identity of, you know, masculinity and being a real man, so to speak, by fathering a child, and the fact that that might not be happening naturally doesn't lessen a man's appeal, his virility, his masculinity. He's still every much of a man, and in fact, the ability to step up, participate in these procedures, and do whatever it takes to help his wife or female partner have a baby together, it makes him a real man, because to be able to put aside those ego concerns and do this shows their real masculinity and their real love for their female.
That's perfect. Because that's what we're hoping to have the conversation about. That real what is real you or how you feel isn't the process. It's how you behave within the relationship. So those are powerful. Those are two powerful pearls. And I'll just turn it over to Sara in case I've been talking and asking to see if she wants to jump in.
Just as a poignant reminder of this little point, when we were talking about this presentation earlier in the week, last week, I brought up the case of. It's an old story by now. The kid is in his 20s, but one of my more touching moments as a reproductive endocrinologist is when a married husband, a man without sperm, and this is way before the days of even thinking about testicular extraction, went forward and they did donor insemination, and the wife got pregnant, had the baby, and we had a little baby party celebration, and they came there, and this guy threw his arms around me and thanked me for getting his wife pregnant. That she so much wanted a baby, and he so much wanted to be a father that we made this possible through donor sperm. The man was hugging me and thanking me, and I really found that a touching moment. And as I said, this was a real man. The fact that he didn't have sperm didn't make him less a man. The fact that he did what it took to have a family and made him a real man. And it was a very touching moment for me because no one really knows how they're going to feel until they're in certain shoes.
Right. Thank you for sharing that. I forgot that I didn't forget the story, of course, but that was perfect to follow your pearls up. That who you are as a man speaks so much by action, not by words.
Right.
And I think that's a beautiful, sharing. So thank you, Sara.
Yeah, I'm just listening. What can I say to top that? I figure
there really isn't.
You get there when you're there.
Right. So, Doctor, could you please just share with everyone how if I've been looking to see if anybody was tweeting a question or asking a question through emails, because sometimes there's a lot of listeners on the line, but they don't feel comfortable maybe right now in real time asking you a question. So if what would be the best way? I know they can get a hold of you through me, but I would love for you to share how they can contact you directly.
There's three ways that couples can feel comfortable asking questions after today. Our website actually has an Ask the Doctor section, so it's pretty anonymous.
Okay.
And it's our website, which is havingbabies.com. So there's each doctor rotates weekly to answer questions. I happen to be the doctor of this week, but if a couple listening would like me to particularly answer their question, they can submit a question and ask to be, to have me respond. That's one way. Or, of course, one of my wonderful colleagues will answer the question.
So that's your personal Ask Me Anything, right? That Ask Me Anything site they can go to. So people can go to havingbabies.com and submit a question through Ask the Doctor. And then specifically...
they can submit the question there, and there's a male infertility section plus other subtopics. The benefit of it is they're anonymous, and they can also see what other people are asking. That's kind of nice. Again, you're not alone. You might find that some of your questions are already answered. But on a more personal level, I can be reached through my website at Feinman, Feinman, at havingbabies.com. And I was going to mention before, there is this FDA trial that we're doing for women 35 to 42. Male infertility is welcome. And they can either contact me at that website or at the Encino office at 818-788-7288. Women 35 to 42 who have not had more than 2 fresh IVF cycles are potentially eligible, and I would chat with them over the phone briefly or through email what the qualifications are to be eligible for that study. The study allows them to participate in an IVF cycle at a huge discount.
Okay, and the phone number again?
818-788-7288.
Perfect. So thank you so much. We so appreciate your sharing and the stories and your wisdom and your inspiration. So thank you, and I'm sure you'll be hearing from women clamoring, because I know I want to learn more about that study so that I can share it throughout my website also. So thank you so much. We appreciate it.
Well, thanks for including me.
Please visit our website to learn more and to receive ongoing support from the male fertility community. Mark your calendar in June for the week leading up to Father's Day and join the live conversation about man parts.